So today I'll be dealing with the chest X-ray findings, CT findings, and a very few slides regarding the lung ultrasound also, all pertaining to COVID-19. So I will start with chest X-ray. Chest X-ray is the mainstay imaging tool to diagnose COVID-19, which helps in the decision pathways and management. So the advantage of chest X-ray is that we can use portable X-ray units so that we can take it directly to the COVID ward, so that the patient need not be taken to the radiology department, causing challenge to or like causing spread of infection to the staff in radiology department. So one radiographer can be he can be given the job of taking portable X-ray, so we can actually reduce the risk of infection if you're using a portable X-ray unit. And it is very easy to sanitize or just keep a plastic cover over the portable X-ray units. So the chance of infection and sanitization is easy if we do a portable X-ray. So that is the main advantage of doing chest X-ray in COVID-19 patients. But there are disadvantages also, because chest X-ray is very insensitive, especially in the early course. That is, if you take a X-ray in the early phase, that is the first 3 days, most of the chest X-rays will be normal. So but in the same case, if we take CT, we can find early findings, which is very difficult to pick up in a chest X-ray. So that is the main disadvantage. But I think the advantage comes over the disadvantage, and definitely sensitivity increases as the disease progresses. So the protocol it may vary from hospital to hospital, but it is always advisable to take a on the first day on the admission, take a baseline chest X-ray, and after that it is advisable to take a chest X-ray on the 3rd day, 7th day, and the 10th day. It actually depends on like it varies from hospitals to hospitals. So this is the disadvantage, as I already told. It's a chest X-ray which looks normal, but on the corresponding CT we can actually see a early change which is seen in the right lower lobe, a ground glassing. But the main advantage of chest X-ray is that we can actually follow up the patient. That means this is a series of chest X-rays, which it is taken at admission 4 hours, 24 hours, 48 hours, 22 hours. So here you can see multifocal consolidation, and after like 24 hours, we can see that it is increasing, and finally it's almost a whiteout lung there. So it actually helps in the helps to know the progression of the disease. So that is the main advantage of the chest X-ray. So now, like the American College of Radiology, along with the RSNA, that is the Radiological Society of North America, they have actually come with a standardized language. So today I'll be dealing with that standardized reporting format of chest X-rays. Actually, that is very important, because the radiologist and some of the clinicians may write in its notes. I don't know in how many hospitals the radiologists are reporting the chest X-rays. Most of the hospitals, the clinicians itself are interpreting the chest X-rays and writing in the case reports. So most of the time, we radiologists as well as the clinicians is using different terms like hazy opacity, heterogeneous density. Some say it is a patchy opacity. So the reporting formats, actually the words used in the language used in the reporting varies from different clinicians as well as the radiologists. So it will be difficult for the clinician to actually take a decision on our reports. So they have come across with, so that is the same with chest CT, chest X-ray, and lung ultrasound. They have actually come out with new terminology or a new standardized language, so that all of us can do the same thing. So that will help the clinicians for further decision making. So today I'll be dealing with that standardized reporting format of a chest X-ray, so that each one of you can follow that, so that you can write in your case sheets likewise. So the importance of standardized language, it establishes uniform reporting regarding the presence of pneumonia and its extent. So as you all know, COVID-19 pneumonia is actually more dangerous. So in the chest X-ray, our main aim is to find out whether pneumonia is present or not, and if present, what is the extent. So it reduces reporting variability, and it provides clear communication for clinical decision making. So this is how there's only 4 terminology in chest X-rays. So this comes under the category, that is, it can be either negative, it can be indeterminate for pneumonia. That's the second the word. Third is focal pneumonia, and fourth is multifocal pneumonia. So there are only 4 terminologies that we use for reporting COVID-19 chest x-rays. So I'll be coming in detail. So this is a, so I'll be just showing you few cases so that you will know like how we are reporting. So this is a first case. It's a 54-year-old male with so many comorbidities. He came with a new onset, new low grade fever and cough. A chest X-ray was taken, which is actually he has a pacemaker, but apart from that, he has cardiomegaly. The lungs actually is clear. So there are no findings, there are no opacities, nothing. So the report should be the clear lungs, no radiographic evidence of pneumonia. So it will be NP, no pneumonia, NP. So CXNP, that's how we report. CXNP. So there is no radiographic evidence of pneumonia. So if the lungs is clear, we have to report like no pneumonia. So in your case sheet also you can write no pneumonia. So that is the body first part. So he is actually confirmed COVID-19 by PCR, but the test is clear. He was hospitalized, no need of ventilation, and he was discharged after 4 weeks after negative report. So that is the prognosis part. So the chest is clear. The patient being discharged without any further deterioration, it's actually, we can actually give the prognosis if the lungs is clear. So second is, he is a 59-year-old who comes with cough and shortness of breath. On admission, actually, a chest X-ray was taken. Here, it is showing subtle abnormality with increased markings in the right lower lobe. But luckily, the patient had a previous X-ray. So when we check the previous X-ray, the findings are remaining the same. There is no new finding. So the teaching point is that you have to always ask for a previous X-ray. The patient comes to a department, always, especially in this setting, because there are so many, there are chronic illnesses which can cause the same finding. So luckily for this patient, the patient had a previous X-ray and it was almost the normal. So in this case also, because there are no new findings, in this case also we report as no radiographic evidence of pneumonia. So the teaching point is either the lung should be clear, or if some finding is there which is present in the previous chest X-ray, no new finding. So if there is no new finding or the lungs is clear, we give it as no radiographic evidence of pneumonia. So that is the first part. Now coming to the second, that is indeterminate findings for pneumonia. That is the second terminology that we use, IP, indeterminate findings for pneumonia. So we'll come with a case. It's a 33-year-old again with comorbidity. He is a known case of dermatomyositis and interstitial lung disease. He also had a previous X-ray, but there is some suspicious new finding here. So in this case, there are definitely some patchy opacities here and there. There are some small chronic linear patchy opacities. So we are not sure if the patient is having COVID-19 or not. So for these patients, we take a CT chest, but again, the CT chest is showing peribronchovascular, that is central, some linear fibrotic strands, which is same as that of the previous CT. So this we give because there are suspicions of some new findings, but it is not typical of COVID-19. So we give it as indeterminate, IP. So if the patient has a history of exposure, and clinically we feel that the patient has COVID-19, we should always go for a CT test. So that is the importance of indeterminate finding. We are not sure that it is COVID-19, but there is a chance. So in this case, it is the same finding and the COVID report came as negative. So this patient just had a flare-up of her ILD, that's it. So this is indeterminate. Next case, it's a 80-year-old female with cough and shortness of breath. CT chest X-ray was taken. It shows here you can see mild hazy basilar interstitial opacities. It is bibasilar. It is not consolidation. You can only see some interstitial opacity. So if you are not seeing frank pneumonia or consolidation, we have to give it as indeterminate. And indeterminate because the patient is old with cough, shortness of breath, CT was taken. CT showed typical findings of COVID-19. So in this case, it is indeterminate. So if we are not finding a frank pneumonia, but some interstitial markings which are bilateral basal, we again give it as indeterminate. And if the patient is high risk, we have to take a CT test to confirm. Again, next case, it's also an indeterminate finding that you can see bilateral interstitial opacity. So it can be either a pulmonary edema, we are not sure, or it can be interstitial pneumonia, again, we are not sure. So in this also, this is a 66-year-old with cirrhosis. Again, comorbidity is there. So we took CT, and CT also showed bilateral ground glassing with septal thickening, highly suspicious for COVID-19. So again, we have to give this as indeterminate. So the learning point is that if we see interstitial markings, if we are not seeing frank pneumonia but mild hazy opacities or interstitial markings, we have to give it as interstitial. That is positive for interstitial. It is like indeterminate. Indeterminate for pneumonia, IP, CXIP, and if the patient is high risk, you have to go for a CT chest. Now coming to the third terminology, that is FP, that is focal pneumonia. If we see a pneumonic patch in one side, so in this case, he is a 43-year-old female, otherwise healthy. He is seeing a unilateral light lower lobe opacity. So here in this case, we can give it as FP. It is non-specific and it can be seen in bacterial pneumonia as well as early COVID-19. So again, if the patient is symptomatic and like comorbid conditions are there, you can take a CT, or it's always better to take a CT chest in this cases. So if you are seeing a patchy pneumonia like this, you can give it as FP or focal pneumonia. Another case, 71-year-old. This one also you can see like for unilateral left mid-lung opacity. There's an additional opacity in the left upper lobe which is obscured by the scapula. So CT chest is taken. We are seeing ground glass opacity with some septal lines. This was also COVID positive patient. So these are all early findings in COVID-19 which can present as focal pneumonia. Now, another case, it's again, this is a chronic finding, chronic atelectatic lung, but here also a patch opacity. So this patient was negative for COVID-19. So a focal pneumonia can be bacterial pneumonia also. That is why we give it as FP, that is less typical for COVID-19. So it can be either an early COVID-19 or a bacterial pneumonia. So this actually came out as bacterial pneumonia, not COVID-19 pneumonia. Again, there are two findings which we are almost sure that it is not COVID-19. These are, if you see a consolidation with cavitation. And here in this case, we can see a lobar pneumonia, which is involving the right middle lobe. You are seeing the cardiac margin obscured. So it is a lobar consolidation involving the right middle lobe. And here in this case, we are seeing a pneumonia with cavitation. So these two findings are very, very unlikely in COVID-19, and it is highly specific for bacterial pneumonia. So in these cases, actually, there's no need for taking a CT chest. We can right away label it as bacterial pneumonia, and the patient can be started on antibiotics. So please remember these two findings, which are highly, highly atypical for COVID-19. That is a consolidation with cavitation or a lobar consolidation. Now, the fourth terminology, that is the multifocal or bilateral pneumonia, we call it as MP. So CXMP, that is almost a typical appearance for COVID-19. So this was in the day 2 of the patient, the chest X-ray was normal. And now at the 7th day, the patient came back with increased like progression of his dyspnea. So when a chest X-ray was taken on day 7, we are seeing multifocal consolidations. Multifocal consolidation, you can see it is predominantly in the basal area. Again, very, very typical of COVID-19. The CT chest was taken. CT chest almost showed the multifocal ground glassing and some consolidations here and there. So this is the typical appearance of COVID-19. So multifocal or bilateral pneumonia. This patient this was a confirmed case of COVID-19. And now this is a 71-year-old. Again, this was the chest X-ray I was showing in the focal pneumonia. So this actually after 1 week, the patient came back with increasing breathlessness. And now the same patient, now he developed multifocal pneumonia. Again, very typical of all these multifocal pneumonia are known case of COVID-19. So this is a typical appearance. Again, another case showing multifocal pneumonia. The corresponding CT is also showing multifocal pneumonia or ground glassing. Again, typical. This is a severe case, multifocal consolidation. Here also you can see almost organizing pneumonia pattern and multifocal consolidation. Again, it is confirmatory for COVID-19. So another case, bilateral multifocal opacities with mid to lower lung distribution, typical for COVID-19. So the RSNA, that is the Radiological Society of North America, has come with the conclusion that use of chest radiography will likely to continue to increase as the COVID pandemic continues, because as we are now we are in almost such a state where we are seeing a lot of patients each day, and taking CT chest for each and every patient is almost not practical. So actually we have to depend on chest x-ray for the diagnosis as well as the follow-up of all the patients. That is what in US right now they are practicing. So chest x-ray is often the only imaging test performed in the evaluation of COVID and is used more frequently than CT in the US. Chest X-ray aims to identify presence or absence of pneumonia or an alternative diagnosis and is a tool used in decision pathways and patient management. Multifocal bilateral pulmonary opacities are non-specific but most characteristic of COVID-19 pneumonia, and standardized language establishes uniform reporting as to the presence or absence of pneumonia, reduces report variability, facilitates for analysis, and also provides clear communication in aid in diagnostic and management decisions. So that is the importance of chest X-ray right now. I think like in all the government hospitals, we have a portable X-ray unit, and if we follow the standardized language or the standardized reporting format, I think it is easy for all the clinicians to actually diagnose and actually tell the prognosis of the patients. Now coming to chest CT, the findings in chest CT, all of you know, I hope. But the indications of CT chest, actually, there is not a consensus at right now, like who all go for the CT chest and who all go for chest X-rays. In American College of Radiology, they don't advise CT chest, especially like they advise CT chest only for that very severe patients who are not responding to treatment. But in European College of Radiology, they is actually advising CT for even in the first stage itself to prognosticate the patient. So the imaging or the chest CT is indicated if the RT-PCR testing is not available, and it is available but results are delayed, and initial RT-PCR negative but with high clinical suspicion of COVID-19. So in CT test, actually we can almost diagnose COVID-19. So in most of the cases, that is the main indication now. That is RT-PCR is negative, but we have very high clinical suspicion of COVID-19. And if the patients have severe symptoms or signs on physical examination, have presentation that could represent complications of COVID-19, to help with the disposition or triaging. So this triaging of the patient actually with CT test, it's actually easy. So we can actually, if the CT test is negative, actually we can almost sure that he's not having a severe COVID-19, maybe a mild infection. Or so the triaging of the patient is also, it is actually easy with CT test. And if in suspected or confirmed COVID-19 cases, we can do CT chest if there is a higher risk of disease progression. That if a patient have comorbidities, we can know like how much these, like in chest X-ray, it is actually difficult to say how much of the lung is involved, or like the correct prognosis. We can actually, it's very difficult to see in to tell in using chest X-ray, but CT we can accurately tell like how much of the lung is involved, and we can clearly tell like what will be the prognosis of the patient, whether the patient needs ventilation or the patient will improve. So all those things like regarding the further progression and the prognosis of the patient, the accurate we can actually accurately tell only using CT chest, not chest X-ray. So in patients not responding to supportive treatment and who presents with acute clinical deterioration, CT test is very helpful. So the main findings, I think many of you know, it is the peripheral ground glassing. So what is ground glassing is, it is just an opacity in the CT chest where the vascular markings are not obscured. So you can see the vascular markings here, but we are seeing some density here. So that is ground glassing. Consolidation is, it is a denser density where we cannot see the vascular markings. So that is the basic difference between ground glassing and consolidation. So early findings in COVID-19 is bilateral peripheral ground glassing that you are seeing here. And in a later stage, we can see crazy paving. Crazy paving means you can see linear lines here. That is actually the septal thickening. As you know, there are numerous, there are interlobular and intralobular septa within the lung. And if that septa is thickened along with ground glassing, so we should have a septal thickening plus ground glassing. That is called crazy paving appearance. That is actually seen in a later stage. So early we can only see ground glassing, and as disease progresses, that maybe after 1 week, in 10 days, the disease is progressing. That may lead to fibrosis. So fibrosis in CT chest, it is evident by the septal thickening, subpleural fibrotic bands, traction bronchiectasis, and so many other changes in fibrosis. So crazy paving is important in late stage of the disease. Other findings that we see in CT chest is that this is the vascular markings, that there will be dilatation of the vessels. So that is secondary to the inflammation in the lung. That is the dilated vascular markings. Next is traction bronchiectasis. Traction bronchiectasis means because of the fibrosis of the surrounding lungs, it pulls the bronchi. So as a result, the bronchi get dilated. So that is called traction bronchiectasis. So traction bronchiectasis, again, it is seen in a later stage. So it suggests that the surrounding lung is undergoing fibrosis. This is the subpleural band I was talking about. So this again shows fibrosis. So all these findings, so except ground glassing and consolidation, all these findings, that is crazy paving, traction bronchiectasis, subpleural bands, all these are result of the fibrosis, which is seen in the later stage. So this architectural distortion and subpleural bands, like what you're seeing here, which is seen in the later stage. So these findings of fibrosis are actually ominous, that we don't know whether there are no studies as such to prove that all this fibrosis will get resolved. There are some studies coming up in US as well as in Europe. So they are telling that all these, the progression of the disease is such that in the early stage, we only see ground glassing or the partial crazy paving. Progressive disease, we'll start seeing increased crazy paving, peak stage consolidation, and absorption rate is more than 14 days. So around 50%, there is not, the actual studies are actually going on. The results are not out, but they are under the consensus that around 50% will have complete resolution of the findings, but 50% will have this residual fibrosis, which again is very ominous, because they think that it is not resolving, and ultimately the whole of the lung gets destroyed, and ultimately the patient has to undergo a lung transplantation. So I think that's what happened to our dear S.B. Balasubramaniam, who recently just now passed away. So that is actually the scary part of the COVID-19, that fibrosis. So if the patient only has ground glassing, and if we follow up the patient, it most of the time it gets resolved. But if it progresses to the later stage, that is more ground glassing and more fibrosis, that fibrosis part will not get resolved, and ultimately the lung capacity will get reduced. So this is the early findings. You're only seeing ground glassing, there is no fibrosis. This is again around the intermediate stage. We are seeing ground glassing, but we are seeing some findings of fibrosis. That is the subpleural bands, that shows that fibrosis has set in. And this is a later stage. We are seeing it's frank fibrosis. Ground glassing is there, but you are seeing traction bronchiectasis, subpleural band. See, these are all fibrotic changes. So this patient has undergone that final gone into that fibrosis stage. And this is important in the, like the standardized language that we said in chest X-ray. In CT, we give CORADS reporting. That is, again, so we have a standardized reporting format, so that the clinicians will be knowing like what is the severity, or like what is the suspicion of COVID-19. So this is similar to all the RIDES, BIRADS, TIRADS, PIRADS, ORADS. We have so many RIDES now. So this CORADS also the same thing almost, because the CORADS 1, that is normal or non-infectious abnormalities. CORADS 2 is, we are almost sure it's not COVID-19. So we give it as CORADS 2, but there are some findings which are not, which is highly unlikely for COVID-19. CORADS 3 is maybe it's an early finding, can progress to COVID-19. CORADS 4 is it is like suspicious for COVID-19, but not the typical finding. 5 is typical COVID-19. So I'll show you the cases. This you're seeing small centrilobular nodules and tree in bud pattern. This nodules is very, very rare in COVID-19. So we'll not see nodules in COVID-19. So we give this as CORADS 2. This is also CORADS 2 lobar pneumonia. When we discussed the chest X-ray, I told lobar pneumonia with this centrilobular nodules is very typical for bacterial pneumonia and infectious bronchiolitis. So we give as CORADS 2, that is COVID-19 highly unlikely. This is COVID. This is CORADS 3. These are 4 different cases. You are seeing unifocal ground glassing. It is not multifocal. It is not bilateral. This can be an early COVID-19. We don't know. So we give this as CORADS 3. This is multifocal ground glassing, but it is not bilateral. This is bilateral, but it is not basal. So this can be COVID-19 and it's suspicious of COVID-19, but it doesn't have the typical appearance of COVID-19. Then we give it as CORADS 4. And this is the typical CORADS 5. We are giving multifocal, bilateral, basal, predominant ground glassing and the consultation. So as a radiologist, we have to give this CORAD score for all patients who are suspecting COVID-19. So these are the typical findings, typical and very atypical. That's what. If we see cavitation, tree, bud, nodules, mass, pleural thickening, we give CORADS 2. And if you see all these typical findings, we give CORADS 5. And this atypical findings, we give it as 3 or 4. And now the CT severity index, CT severity score, that is also very important in predicting the prognosis of the patient. What we do is, there are 5 lobes, as you know, right upper, right middle, right lower, left upper and left lobe. So 5 lobes individually we see. This is actually a subjective quantification. Each lobe we see how much of the lung is involved, either by the ground glassing, either by the consultation, or either by the fibrosis. If it is less than 5% involvement is there, we give it a score 1. 5 to 25%, that is 1/4 of the lungs is involved, we give it as 2. If almost half is involved, we give it as 3. If it 50 to 75, 4, and more than 75 involvement is, give it as 5. So one lobe we can actually give a score of 1 to 5. So the minimum score is 5 and maximum score is 25. So it ranges from 5 to 25. So if we give the score, the clinician will get the idea that how much of the lungs is involved. So as per that, they can actually give the prognosis to the patients. So this is the possible role of CT. This is the helps in the triage, helps in the prediction of worsening, helps in the prediction of improvement, and is often a problem solver in many cases. So I'll just be showing the 3 COVID-19 positive cases that came to our department. So this is a 60-year-old male who came with fever and shortness of breath. This CT was taken on the 8th day after the onset of symptoms. This patient was not a COVID-19 positive patient when he came to our department. But when we took CT, the findings are so typical of COVID-19. We are seeing this multifocal consolidation, peripheral consolidation. So the CORAD score that we gave us CORADS 5 because of the multifocal pneumonia. And coming to how we say the severity index. So we coming to the both upper lobes, that is only less than 1/4 involvement in both the upper lobes. Actually, in all the upper lobes, it is less than 25 involvement. So it will be 2 for each lobes. So that becomes, you can see the coronal also. It is involving less than 25% in all the lobes. So 5 into 2, the score becomes 10. So the clinician will get an idea that only like out of the 25, his score is only 10. So it's having a mild to moderate form of the disease. So that's how we report CORADS 5 and CT severity index 10. And that patient, ultimately the COVID report came as positive. And this is another patient, again came to our department. So this patient right now has a severe disease. Again, very typical, bilateral, peripheral, consolidation, ground glassing. You can see the right upper and lower lobe is severely involved. Almost 75% is involved, bilateral lower lobes. You can see frank consolidation here. So again, CORADS 5 because of multifocal involvement, multifocal bilateral involvement. CT severity index, actually 3 lobes, this patient has around 75%. So give it as 4 into 3. So that becomes 12. And 2 lobes, that is right middle lobe and left upper lobe, there is only around 25 to 50% involvement. So the 2 lobes we give it as 3. So 6 plus 12, the CT severity index, it becomes 18. So out of 25, this patient had a score of 18. That shows that most of his lung is involved. So again, very, very bad prognosis. So this is the mediastinal windows. It shows the consolidation. Again, the same patient, that's a coronal view. You can see how much of the lungs is involved and the severity of the disease. This is another patient. This is just show the very minimal involvement. Actually, this is again taken in a later phase. Only two lobes are involved. That is the right lower lobe as well as the left upper lobe. Less than 5%. So the CT severity score is only 5, very mild disease. But that part of the lungs is fibrous. You can see that is actually the fibrotic changes you can see here, because you can see that subpleural bands. So so the disease is actually very mild. It's only involving less than 5% in only two lobes, and the three lobes are almost spared. But whatever lungs is involved, it got fibrosed for this patient. So this is how we gave the CORAD score as well as the severity. Hope it is clear to all. And now a few slides. Do I have time to continue the lung ultrasound? Only a few slides. I mean, just the very basics of lung ultrasound. Shall I continue or?
Yes, please continue.
Okay, so the very basics. I don't know how much it is important for you. So this is how we take the we divide the chest into 6 areas. That is anteriorly the parasternal line, anterior axillary line. We have 2 segments here. Here between the anterior axillary line and the posterior axillary line, 2 segments. And posteriorly, that is between the midline and the posterior axillary line, have 2 areas. So we have to keep the transducer in the intercostal space that is perpendicular to the ribs. So actually the importance of lung ultrasound is that it can be very well used as a bedside tool. So again, as we all know, it is very difficult for all the COVID-19 patients should be shifted to the radiology department. So this actually, even the critical care people or the radiologists or the clinicians, all of us, if they are trained, they can do this lung ultrasound, which is actually very helpful in actually even in diagnosis also. It actually helps. So this is a normal appearance. This is the shadow of the ribs. So you have to keep the probe perpendicular to the ribs, so that we can see each intercostal space like this. So this is the normal lungs. You can see this is the shadow of the ribs. So this is the normal reverberation artifacts which are seeing as horizontal. That is normal. The reverberation artifacts occur due to the interface between the pleura and the lung. So this is normal. So, and sometimes we can see a vertical line. This is called the B line. And if you see one B line, that is also normal. But if we see numerous B lines, or if we see subpleural, so this is the pleura. So if you see subpleural hypoechoic or black areas like this, we have to suspect subpleural consolidation, which is typical for COVID-19. So this is what we look in lung ultrasound. If we see subpleural hypoechoic or black areas, we have to suspect COVID-19. This is again another patient with where we can see consolidation. Consolidation means we see the lung just like the liver. So it's called the hepatization of the lungs. So if we see hepatization of the lungs with this small hyperechoic streaks, that is actually the air bronchogram. This is the appearance of the consolidation. And this is again a large subpleural consolidation. And this is what we see in ground glassing. This is the coalescent B lines, that if you see this thick vertical lines in between the rib shadow, that is characteristic of ground glassing. So these are the findings which are ominous for COVID-19, that is the coalescent B lines, the subpleural consolidation and the consolidation. So these are the findings you have to, but the people who are doing in lung ultrasound, they have to be actually trained for, then only like we can see all these findings. So this is the technique, and this is how we have to report. I don't think it is very important for you. And you have to see for the pleura, and again, not very important for you. You had to see the diaphragmatic mobility, chest wall, and other findings. So to conclude, actually, I have touched upon the chest X-ray findings. That is what I think all of us are, like most of the clinicians will be using. The standardized language that we use in chest X-ray, the CT chest, again, the standardized reporting involved using the CORADs as well as the CT severity score, and finally a few slides in the lung ultrasound. So I conclude by saying that whatever the modality is, there should be a standardized language or standardized reporting format, so that all the clinicians will know about it, and it actually helps in the decision making rather than giving very vague reports. We have the standardized reporting format, it will be very easy for the clinicians. So that's what like we radiologists are trying to use, and I think for you also, I think it will be very useful. Thank you. Any questions? I hope it was clear. I was going very, like it was clear, I hope.
താങ്ക് യു രശ്മി, വളരെ നല്ല പ്രസന്റേഷൻ ആയിരുന്നു. എന്തെങ്കിലും സംശയം ഉണ്ടെങ്കിൽ അൺമ്യൂട്ട് ചെയ്തിട്ട് ചോദിക്കാം.
Hope it was clear, the
Yes,
standardized formatting, the report formatting, and see, in your see, you're all COVID treating people, right? In general hospital and all, like you usually do CT chest or chest X-rays?
സാധാരണ